Good morning. This is a neonate with persistent jaundice. So this is a 40-day-old boy, term, normal delivery, good birth weight, on breastfeeds, an antenatally uneventful history. He developed unconjugated jaundice requiring phototherapy, but on day 10 of life, this child was discharged thinking that the jaundice is reducing, but actually the high-colored urine had started coming up. So the pediatricians did not realize that he was going into cholestasis. So there was jaundice with pigmented stools, on breastfeeds,
Moina,
no
just
seizures.
stop here. I would like to give this question to the audience here as to what do you think has happened? What has changed in this? Moina has said already something, but then I think we can go a step forward. And so what has happened here? There's jaundice, there's pigmented stools, and there is a direct hyperbilirubinemia here with a high-colored urine in this baby. So what has happened from birth to now? Something that should actually is a red sign, something that should have asked us to get the child back to us later, even if we discharge this child at this point. So I would like to know what is there. Somebody just one person loudly. Yes. Why do you say cholestasis?
Because high-colored urine is there.
And no, direct hyperbilirubinemia? High-colored urine, good. Why do you say cholestasis? Something else? Can you see there? Pigment. Okay, so there is still pigmented stool. So we really cannot say cholestasis at this point of view, but definitely this is direct bilirubinemia. Go ahead.
One point what we need to stress here is at day 10 the jaundice has been picked. The change in the bilirubin has been picked up. So as from a general pediatrician's point of view, the main thing is once we discharge a newborn, these days newborns are discharged at day 1 or day 2 of life. It is always better to have a first follow-up of the child at 1 week.
Yeah, that's exactly
what I said. So we can pick up clinically
yes.
if the child is going into jaundice and then investigate.
Thank you, Shaitan. That's exactly what our message should be, that the child should have been called back.
So weight gain 12 grams per day, not very good. Day 20, blood in stools. It resolved spontaneously. Then in the last 15 days, progressive abdominal distension and 6 days of poor feeding, intermittent sucking. Remember, this child is still on breastfeeds and he lands up to us on day 40 of life. If you look at the family history
Just go back a bit. Now, what do you think has happened at day 40? What is this child at this point of time? If you give him based on history, if you want to give him a syndromic diagnosis, what syndromic diagnosis would you be using here? I would put it, go back to Srinivas, as to what syndromic diagnosis you would give here, and
I suppose neonatal cholestasis is what you want to give.
Syndrome. And what else beyond that? What else has happened in here?
This baby is also seemingly a sick baby who's now come in with poor feeding, intermittent sucking. So we need to consider conditions where the baby may be sick with neonatal cholestasis.
So this is a sick baby. This is a sick neonatal cholestasis syndrome. So something else that you think is there, and Dr. Jacha, is there something else that you think is there? And
Blood in stool.
There has been a little bit of progressive abdominal distension as well. The blood and stool, I'm not sure. You haven't given enough information for me to really comment on that.
Yeah, but then it is there and need to be kept in mind. If nothing else, we don't react to it, but we at least be kept in mind.
You like to know whether there were any other skin bleeds, any other mucosal bleeds?
No, so far no skin bleeds. No.
And whether there's sometimes, in small children, you also find little specks of blood in the stool. So how significant that was, you have to give some information.
Very correct.
Okay. So family history, if you see on the mother's side, there has been one unexplained death. We don't have too much of details, but this parents have lost 3 consecutive children, day 85, day 35, day 65, all presenting with conjugated jaundice and ascites from day 15 of life, documented. One of them having seizures, one of them ending up with spontaneous bacterial peritonitis, which went to a surgeon and an exploratory laparotomy was done. But that's a different issue. And a skin bleeds, and one of the other children had a skin bleed. They have a sibling who is normal, and the index case is the one we are discussing.
Again, I would go back to Srinivas and ask you, would you now give importance to that speck of blood in the stool?
Certainly, I mean, like every single symptom, I think we do need to pay attention to. I would also go back and ask you the same question: were all of these children exclusively breastfed?
All were exclusively breastfed. All.
So I think this pedigree chart, I think, gives us a lot of information. It's very unusual for somebody to have recurrent symptoms in a family unless and until there is some metabolic disorder going on in the family or some form of an inborn error of metabolism. And the fact that all of them have had a very sick neonatal cholestasis syndrome, all of them have been exclusively breastfed, very, very high on the cards very early on would be something like galactosemia that I would consider.
Okay, let's just not go into the diagnosis as yet. What I feel an important message that should go from here, so Shant, would be from this particular slide, if you ask me. What good message can go to the audience right now?
The family screening and the family history is the most important.
Very important.
We have to spend 5 more minutes more on the history so that we pick up all these things.
So if we summarize as it has been summarized, the points that we note in the family history: this is a non-consanguineous marriage, recurrent SIP deaths are there, always in the first 3 months, affecting both sexes. Remember, one child is alive, so this is not probably an autosomal dominant problem. All the children had jaundice and ascites. One had SBP, coagulopathy, and the terminal event being sepsis and seizures.
I think I would also agree with the person in the audience. I don't know his name because yes, fantastic, sir. Because I keep telling all my postgraduates whenever they take history, when you start writing the history, the question is not what you came for. The question is, who are you? Whom did you bring your child with? You get to know the family. So I think the history taking should start only with the family background, what the father does, what the mother does, and how many children they have.
Yes, Srinivas, but in this particular session, I want to stress on the family history, keeping in mind that is there other affected family members? This particular session only. Yeah.
Okay. So, for the audience, this is a day 40 child. We know this is neonatal cholestasis. We have progressive abdominal distension, suggesting ascites or organomegaly, but I'd like to think of ascites more because the previous siblings had. Coagulopathy, then there is recurrent SIP deaths. And this is a sick baby. So all these point to a metabolic liver disease.
So please go back. So now what we have in front of us is a neonatal cholestasis syndrome based on the history that we have. And of course, like he said, this is a sick baby. So what are the pointers? The family history, that's one pointer. The blood and stool, that's coagulopathy. Now what is he actually trying to say, sir? That this is a metabolic syndrome because there's blood and stool. This is a metabolic syndrome because there is a progressive abdominal distension. Why would these two things be used to call it a metabolic syndrome?
You're asking me?
Yeah.
Now, I think because of the 3 SIP deaths, we have to think of a metabolic disease. There are non-metabolic diseases also which can give rise to this kind of a phenomenon. So that makes you think, yes, see, no infection can produce like this, no biliary atresia occurs like this, no neonatal hepatitis like this. So your finger should be always on the metabolic liver disease in view of the family history, which is very strong here. And then the question will come, and the child is, there may be sick baby even in septicemia, it can be a UTI, but that's a different story. It is because of the family history and the natural history of those 3 deaths which have taken place in the early part, second month, almost all the babies have died because of the liver disease. So we have to think of a metabolic liver disease.
So I agree that the family history is the major pointer here. But is progressive abdominal distension and blood and stool coming very early, almost by day 30 or something, is that also a little bit of an indicator towards metabolic liver disease?
They won't be actually, see, like coagulopathy can occur as early as 5 days, 4 days, you know, congenital hemochromatosis. In fact, coagulopathy may be the first presentation rather than the jaundice. So that doesn't actually make early coagulopathy or late coagulopathy, that will not probably make us to think even biliary atresia patients, even herpes infection can give you coagulopathy that is in the first 1 week of life. So coagulopathy I don't think is a discriminatory factor. What is the second one you said?
Is the abdominal distension, sir?
Abdominal distension, yes, there could be reasons. If you see, it could be organomegaly, it could be ascites. And we know ascites mostly in these patients, unless it is a spontaneous perforation of the bile duct, most of the times it is related to maybe a metabolic disease or early decompensation of any kind of liver disease. So ascites, I think this is a softer point which will take you towards the metabolic disease. I
Synthetic
agree with
dysfunction.
that. That's right.
All these manifestations.
One question there, can we just take that
Just a
quickly?
small comment that
Please take
there
a
could be a
mic.
metabolic disorder which have a predilection for infection to be superimposed. And this is probably the story in all these babies, that they had an underlying metabolic disorder like galactosemia, which has a great predilection for E. coli septicemia.
Yeah, so that is what these
Absolutely,
symptoms can also
absolutely.
be as a part of generalized sepsis, but then
we
considering
will
the family
go
history.
on with that story also. We'll go ahead. Yeah.
Sepsis, see, I would like to just amend that statement. Any newborn baby who has jaundice, which is conjugated, and is sick, not lethargy, poor feeding, activity poor, think of galactosemia as a possibility. I would not say
The
just
family
think of
history.
sepsis. Sepsis is one of the reflections.
That is in fact the overdiagnosed thing in
So
our
it is
this
not
thing every
only,
time.
so you have to think it may be early or it may be a little late presentation in these patients.
Yes, go ahead.
So we'll dissect the case in terms of various parameters. Let's see with the onset of jaundice. These galactosemia starts very early, tyrosinemia slightly later, mitochondrial hepatopathy and hemophagocytosis can occur at any point of time from birth to later. Neonatal herpes simplex and neonatal hemochromatosis probably not we are thinking in this case. If we look in terms of SIP death, intrahepatic causes, galactosemia, neonatal hemochromatosis, tyrosinemia, mitochondrial hepatopathies and HLH. Examination of the child, weight was 3.9.
He just asked the HLH as well as the, I'll just leave HLH, but the neonatal hemochromatosis and the HCV infection, he almost made it fly off. Why do you think was that? Somebody from the audience, and I can take it to the panelist. Somebody from the audience? Just a second, yeah? Yeah? Anybody? The question is that he said that herpes simplex and neonatal hemochromatosis may not be possible as a differential diagnosis in this particular child. Why? I would take it to the panelists now. Yeah, somebody wants to answer, please.
HSV will present early and not so late, and you can't have HSV happening in 4 babies because you know that most of it is related to the first infection. Correct. So that is why I would not think
And
of
what about
HSV.
NH?
NH, I would leave the hepatitis.
Neonatal hemochromatosis.
Srinivas will answer.
Srinivas, yes. Srinivas.
Sorry, I think neonatal hemochromatosis all tend to be sicker, and usually they are starting to, they are very sick very early as well, and they also succumb reasonably early. They never go beyond the neonatal period.
Yeah. So that's the answer, that both these things usually happen within first week of life. And that is why we're not considering them, because this child started having jaundice in the second week of life, isn't it? Yeah. So let's go ahead, yeah.
Examination. Weight, as I had said, the child was underweight. Icterus was there. Very importantly, there was bilateral cataract, mild pedal edema, abdomen, there was organomegaly, liver was 4 centimeters soft, and spleen was 2 centimeters palpable. Child was lethargic, dull because he was hypoglycemic, and the other 2 systems, cardiovascular and respiratory system, were normal.
Yeah, go ahead.
ये छुपा के रखना था ना. Bilateral cataract you should have pasted and asked. See whether they will look for it or not. See normally our residents also, not at this stage but earlier, they never used to see they would not carry actually torch. And when they would get the torch they would see, and cataract is there, the diagnosis is made. So you should have actually hidden this, moderator madam.
So,
That we will discuss.
we'll discuss this later when they come before
That we will
some.
discuss.
Yeah, SGPJ. Yeah, go ahead.
So this child has early onset ascites, so we are thinking there is probably early cirrhosis. What are the causes that can cause early cirrhosis in such a setting? Galactosemia, neonatal hemochromatosis, we just said is probably not possible. Tyrosinemia, mitochondrial hepatopathies. You see the long chain disorders, 3 to 10% can have early onset ascites. Storage disorders, Niemann-Pick, we don't really want to consider here because storage disorders usually have splenohepatomegaly. We are dealing here with the hepatosplenomegaly. So we are ultimately left with galactosemia, tyrosinemia, and mitochondrial hepatopathy.
And there's
Why not- why not-
go
why
back.
not? Yeah. I think
There's one more reason why we are trying to take away the Niemann-Pick type C from this group, at least to my understanding. What is that reasoning?
Niemann-Pick type C usually doesn't present very early. They tend to present with a very mild jaundice around 2.5, 3 months of age. It's a transient jaundice which goes away. So the jaundice actually improves.
And are they sick babies? Are they sick
They're
babies?
not very sick babies. By the time they come around 5-6 months, you start looking at the developmental delay.
So is
One more point
Yeah, sir.
is,
Yes,
if you
sir.
look at the 3 deaths, the natural history does not fit into the
Into,
Niemann-Pick disease. They will not die so early.
They don't die.
They will die later.
So, keeping
Only
these
one
three
thing.
things in mind, that the splenohepatomegaly is usually more predominantly present in Niemann-Pick, the fact that they're never sick or die, and finally, they usually have the CNS involvement later on in life, which is not there in this family history.
Yeah. Only thing is, I'm not very comfortable with the word cirrhosis there. I mean, like ascites does not necessarily mean cirrhosis. So it's just that liver dysfunction which is severe, and there's a little amount of ascites there.
So if we add up all these features, sick child, neonatal cholestasis, jaundice, hypoglycemia, septates, pigmented stools, very importantly bilateral cataract, and early onset ascites with coagulopathy, number one diagnosis that we consider is galactosemia. Mitochondrial hepatopathies, yes, they are also known to have cataract. 8% have eye involvement, out of which 1 is cataract in them. So the investigations in this child, hemoglobin slightly on the lower side, but not no evidence of hemolysis. Platelets normal, count slightly on the higher side, but for day 40 of age we'll probably accept it. CRP was positive. This child, if you see, had total protein and albumin of 6.8 and 2.8, and an INR which was uncorrectable. Ascitic fluid analysis showed a high SAG ascites. There was no evidence of spontaneous bacterial peritonitis, and the culture was sterile. Further investigation.
Just go back a minute. Now that you know that this is a child who's a sick neonatal cholestasis syndrome with a blood sugar, he showed you earlier from outside was 44 at one point. Now, and with cataract, bilateral cataracts present, with the complete picture that you've seen. What is the next very, very important investigation that you do? Just very simple. So fasting blood sugar and reducing sugar in the urine would give you a lot of information, and then of course you can go ahead after that. Yeah.
So as you rightly said, the urine for non-glucose reducing substances, 3 samples were positive, very highly positive. Alpha-fetoprotein, ferritin, eye examination, blood culture was sterile. Urine culture showed.
But when you do the just a second, when you do the reducing substance, what is one thing that you have? What are a few things that you have to ensure before you send these reducing substance samples? Can you take this thing? This is a very important message. So please take a. Yeah.
I mean, if the baby is off feed, you could have absence of reducing substance. So that is mandatory that the baby should be on feeding.
Yeah.
And secondly, when you find a reducing substance, you should confirm that it is non-glucose. And the simple test is to do a Benedict and the stick test, which will differentiate.
So the Benedict test would be positive, and the stick test would be
Negative.
Negative. So this is non-glucose reducing substance. And 3 such, like he's rightly pointed out, 3 such tests would definitely give you a definite answer here. Yes, go ahead.
So everybody is confused. No, you said cataract present, then you said eye exam normal.
Oh, I'm
What
sorry.
is normal?
This, eye examination.
No.
should say cataract. It's
Possibly
it's
outside examination was normal, but they
rest
found
of
the
the
cataract.
The rest of the eye examination was normal.
And the Galliput very quickly was
Go
we
back,
found
go
out
back,
was
go back.
negative.
Now he said they got the Galliput test done, or the Gal test done. I would like to know again, is there some precaution that you take before you send this test? Yes. Again a mic.
The baby should not have received any blood transfusion. That
In
is
the
very-
last?
I mean, preceding 3 to 4 months.
Yeah, roughly 2 to 3 months. I mean, IV take it's 8 weeks at least, but it actually, ideally, should be 12 weeks. Okay,
Can
so
I raise one small point here?
Yeah.
In the differential diagnosis which have been considered here, will absence of raised enzymes is important pointer towards neonatal hemochromatosis and tyrosinosis? Because I have read somewhere that because these are intrauterine infections, you don't mount an enzyme response. Is it true?
Can we have this question in the end? Because right now we're in a flow, and I am going to present a MLD later. I'll answer a lot more than this. Okay, I'll definitely take up this question. Yes, so he said that if the blood transfusion has been given in the past 2 to 3 months, then this test may come falsely positive. So you should try to falsely positive, negative. You cannot rely upon it. So what else can you do to confirm if you can't do it in this particular test? Then what else can you do? Anybody else?
Parents' blood samples.
Parents?
Parents' blood samples can be taken to look for the enzyme activity.
Okay. I mean, that could have come from the parents. Okay. Anything else that we can do apart from the parents? Can we do something in the child?
For galactosemia?
Yes. Is it something to do in the erythrocytes or something? If I remember.
This is erythrocyte. Galliput
Yeah.
is the erythrocyte-based test.
Is there some other test?
RBC test.
Okay, let's go ahead.
I think
You can do the galactose levels, in the urine. And the chromatography of the urine sample also can be done.
Yeah, it's just
also
that
will give
the
us-
same thing holds good.
Cut short.
Yeah.
Investigation.
Yeah. Okay.
I think you should do this is a confirmatory test if the patient has not received the blood
Blood,
transfusion
yeah.
in the past.
It becomes very difficult, sir.
It
if
will
I'm
become
really-
difficult, but then in that situation we will not
Sir, it is very
elaborate on
common.
that.
Sir, it is very common because most of these children have
Most of
received
the
blood for trivial reasons and they then land up with you.
No,
Okay.
if they are on breastfeed still, then maybe plasma galactose levels would also help.
Yeah, that's what you said, blood glucose.
सीधा गैलीपुट एस्टेब्लिश करने में हमारी लैब में 5 साल लगे। अब ये नहीं यही है ना, नहीं सब कुछ होता है, सब जगह होता है, नहीं गैलीपुट की बात कर रहे हैं। This is there is a difference in galliput actually. What you are getting from the market is a semi-quantitative test. It's a very cheap test. This is the RBC enzyme complete quantitative test, which we have established. It takes time.
Enzyme
And,
quantitative.
pardon?
So enzyme quantitative, no, they're not doing at very many
This
places.
is quantitative test. This is quantitative test, well established confirmatory test. Okay.
What they're doing at other places is the indirect glucose oxidase test. Mostly, this is what they're doing.
Pardon?
Sensitive. When you get borderline values is where the problem is.
That is why you find
still
earlier we sent one, that time Srinivas was our resident there. So we sent the test and it showed galliput is positive. This gall test is positive, something like that. Patient did not undergo surgery. It is at our institution, I tell you. And ultimately this turned out to be biliary atresia. And we were late in offering the surgery to that patient. So you should always view the clinician's point of view, total picture, tests. Don't depend totally on the test. You have to use your own.
Srinivas must have done something.
No. He has been a very good student.
He was more decent then, wasn't he?
This was from the lab, private lab.
Yeah.
Private lab, what you need to understand is, they get a level less than 3.4 or something. When you get a level of 2.5, 2.83, which is taken as galactosemia, quite often, for most of the times when you have it, it's almost undetectable. That's the thing where I'm really sure of the diagnosis.
No, can you come again on the mic?
No,
Yeah.
most of the tests when they do, the kit-based tests which are available, they have levels less than 3.4 is significant. That's what they write. So it's positive. So you get levels of 3, 2.8. Quite often these are false positives. Most of the times in galactosemia that you would see is quite often it's literally undetectable. It's 0, 0.1 or below that. And if that is there even in the kit-based thing, you can generally take it that diagnosis is fine.
So how much we should take from that?
It's almost undetectable. Most of the time they will say it's undetectable. or
वो
absent.
कभी लिखते ही नहीं है कि पॉजिटिव है कि नेगेटिव है.
नहीं नहीं वही तो बोल रहा हूँ.
What they will
Detect
write,
नहीं
they will
करते.
write.
Just
This
a
is the
sum,
level
yeah.
you decide now. What is it? Sometimes they write like
But
this.
that's good. That's good. Because if they write less than 3.4 is positive, they are mess. So they It's good that they write a level. That's why I'm saying the value, if it's very, very low, I think it is taken, I should take it.
How much load do you take
That's what I'm saying,
from this?
0.1, 0.2, 0.03, ऐसे आते हैं levels,
That's
which are significant.
So how much do we take in our lab?
Our lab is less than 5.
Less than 5.
5 is undetectable.
Okay.
Less than 5 units per gram hemoglobin. So galactosemia, as you've rightly diagnosed, we put this child off breast milk. We don't have an option in India, so we have to put on soya formula, multivitamin supplements, calcium supplements, because remember, calcium is not going in this child. And for a short duration, we managed the ascites with diuretics, and he responded. So is liver biopsy really required? In this case, we did it. After controlling the ascites, we found early onset cirrhosis with nodule formation. But per se, liver biopsy is not required if you have the diagnosis has been confirmed.
Just 1 second.
Yes, just go back. Yeah.
Previous slide. There are lactose-free formula available in India. Why is it that they are all only soy formula? I think there are non-soy formula which are not having lactose as well.
Which one is that?
Which one?
Simil
We have Neosobi-casein, Simile MCT.
Sir, there is a caution with casein. In galactosemia guidelines, the British surveillance guidelines clearly say casein-based formulas are not to be given for galactosemia.
This is what I wanted, because you said only there are no options in India, there are only soy formula. So I wanted to bring out why casein cannot be used. Okay.
Absolutely.
Go ahead.
You should be very sure. You should see the formulation, what you are writing, what is the content in that formulation. Here, 3 children have died. You can't take a risk. We have to evaluate very thoughtfully, carefully, and then institute the dietary restrictions.
I think the next slide, there's this question, an important question. Was a liver biopsy at all required in these patients where you already have a Galliput test, giving you the diagnosis? Do you think that the biopsy was required, sir? Sir, I'll take the answer from sir.
I don't think, actually, if you have a case in point, I don't think biopsy will add anything additional here in this particular patient. So I don't think it is really mandatory. Even if you are not able to do, your Galliput is positive, patient is doing well, responding to therapy, you need not to do it.
Especially
but because of I think this might be from the academic point of view, that they are trying to look at the natural history of these patients on this thing. So from academic point of view, this might have been done.
As a research, from the research point of view, or from the prognostication point of view, you could have done. But remember, when you do a liver biopsy in this child, you are actually taking some risk because these babies are sick, they have an INR which is very high. So all that has to be thought of, and the liver biopsy doesn't really give you additional information.
Okay, so over the next few months of follow-up, this child is off breast milk. Good compliance, we had no milk or milk products were given. LFT had normalized, coagulopathy had corrected over the next 6 months. Organomegaly had regressed. Bilateral cataract had resolved on its own. There was a steady weight gain and normal development. This is the boy at 6 years of age, you can see with good growth, and his development is normal. He goes to KG, writes A, B, C, D and all the numbers. This is a message from the father.
What is the message? You have not read. What is the message?
So,
it's a very important message. Yes. Let us not lose any more children. Fathers, please to spread the message.
If somebody has classical galactosemia, it will be very unlikely that they present initially only with a cataract with no liver dysfunction. So liver dysfunction is a very predominant feature of classical galactosemia in addition to cataract. Your surgeon would not have been able to operate on this child at all because of coagulopathy. So if somebody had cataract and they didn't have liver dysfunction at that point of time, we do need to consider still galactosemia as one of the causes, but it might have been one of the other variants of galactosemia which we need to consider.
Just one point, when you have liver dysfunction and cataracts, is there any other differential besides galactosemia is what the panel is saying?
Yeah. Let's go. Yeah.
Liver dysfunction and cataract, ma'am, 4 in fact. 1 is galactosemia on the top of the cards. 2, mitochondrial hepatopathy is known to have cataracts in 8 to 10%. Number 3 is congenital disorders of glycosylation. And number 4, which we're not discussing here, is a torch infection. That's a different thing altogether.
Yeah, but with blood sugar low, I think there's one more cause, and that is HFI. Even that can have cataract. So this particular child could very well have been even HFI, except with little less dysfunction.
Okay, so this is our very humble experience of our cases with galactosemia. If you note,
Hereditary fructose intolerance.
okay, if you pay attention to this slide, all our cases had neonatal jaundice. Most of it presented as neonatal cholestasis. They constitute 2% of our referral. All had jaundice, organomegaly, uncorrectable chlopathy 71%, ascites and cataract in 54%. NGRS was positive in most, and 71% had systemic infections, 47% being E. coli. If you see the follow-up, it's been a remarkable follow-up. Only 2 patients died, the rest were all normal. 2 patients died because they were restarted on galactose by themselves and died of sepsis. LFT normalized in 1 to 24 months. Cataract, very importantly, some of them spontaneously resolved, the other surgery need to be done if it is dense and if there's a risk of amblyopia. Development, a little more than half turn out to have normal development. The rest of them might have some language delay and some fine motor delay.
Just wait. There's this question, what is the neurological outcome in our diagnosed case on galactose-free diet? Now, if you see Moinak's flow diagram, the language delay, the fine motor delay, the hyperactivity. This is, I think, first report of so many cases of galactosemia coming from India. Excellent work, and this shows you itself as to what kind of sequelae they may land up with despite having received the lactose-free diet.
Mean time of diagnosis, sir, is age of onset of symptoms were 10 days, diagnosis was 55 days. So there is a delay of diagnosis of about 45 days.
Delay in diagnosis is up to 380 days.
Yes, up to 380.
That's probably the ones that's responsible for the neurological.
Yes, absolutely.
I didn't get your question, Ashish.
That's great.
Yeah.
What is the real long-term outcome, even on a patient who's a very strict galactose-free diet? Suppose you look at them at 15 years of life.
Yeah.
What would you find?
Yeah, there is this very good article that has come recently in one of the inherited metabolic diseases, which was looked up at many cases of galactosemia, and they have found that most of them, vocational activities, they're all okay, but majority have a speech verbal dyspraxia, which is there about 40%, 30 to 40%. But some of them have actually improved by themselves on follow-up. But the speech verbal dyspraxia tends to persist. Primary ovarian failures occur, that is known to occur, and some of them have actually had osteoporosis later in life. So these are the only 3-4 things that they have been able to show.
I'll just add a few things. I mean, like I've had the opportunity to also talk to a couple of metabolic experts who work with galactosemia. When what I understand is whatever function, neurological dysfunction they have, they're all the effect of whatever has happened early on when the galactosemia was not detected. Subsequently, if you actually go through with a dietitian, where all you have lactose, where all you have galactose, it's extremely difficult for an older baby who's not dependent only on formula to completely keep them free of lactose and galactose. With going time,
lactose-free diet in an older child is not possible.
It is not only that.
and so with growing time, they tend to also
And the endogenous
accept.
galactose,
The point is, a baby takes around 300 ml of milk, which is around 7,000 milligrams of galactose. As you grow older, your body is producing 1,000 milligrams of galactose. Whatever diet you give doesn't take care of that 1,000 milligrams.
And it's very interesting.
Endogenous production of galactose. Despite your complete elimination of galactose from the diet. So it is a problem, and it needs to be solved further by all these metabolic experts.
So it's
pathways. Where can we break the pathways?
No, sir, the pathway need be broken. What they had to say was, with growing age, they do accept small amounts of lactose in their diet.
That could be
No, but the thing is, the lentils, the vegetables, the fruit, everything has a little amount of galactose, and it's impossible for an older child to stay away from all these foods completely. So a lactose-free diet is a utopia in an older child.
It's very difficult.
And then there is endogenous galactose also.
Right. These are the two.
And they are responsible for ovarian failures and even for these, sequelae.
Maximum, if you see the nutrition part, see watermelon, for instance, very high galactose levels. So actually, there is some amount of galactose, as you rightly said, in several food items. बट अब सारा बंद कर दें तो फिर खाएगा क्या? इससे बेहतर है थोड़ा लैंग्वेज में प्रॉब्लम मगर ऐश करें.
How do you say no? How do you
now we'll
follow
have
up
to
these
go.
children? How do you
I'm
follow
getting
up
call.
these children?
I'm getting signs from Abha. Yeah, what did you say? What was your question? Go.
Follow up.
How do you objectively follow up these children to know whether they are doing well on a lactose-free diet? I mean, would you rely only on LFTs, or do you think you would also rely on a plasma galactose level from time to time?
You rely on?
Plasma galactose level from time to time.
The plasma galactose levels do not have, whatever literature is available doesn't have much role to play in the diagnosis, nor do they say it has much role to play even in the future follow-up. So what is important is to look up the child clinically, and of course, till the liver dysfunction is persisting, we have to do the liver functions and look at
plasma galactose levels in follow-up, but they've not found a cutoff level to say yes, this can cause developmental delay, and yes, they will.
So then it doesn't really help. It doesn't really help. So it will be unnecessary money spent.
Very good.
Seema,
No. It will help
one
in the
action.
time.
I think.
Yeah.
Can you clarify for the audience, when you keep a baby with suspected galactosemia,
Yeah.
how many hours do you keep them nil orally before you do a fasting blood sugar?
See, what I do in my center is, it's not very clearly mentioned, but what I do in my center is I first do a 4-hour, because these patients usually have a very short period and they're usually smaller babies. So what we do is a 4-hour fasting, and then we do the blood glucose. If the blood glucose is still normal, then we do a 6-hour fasting. Otherwise, if we find hypoglycemia at 4 hours, we end it there and then.
I think that's important because
No, but it's also
That's
important
how we are
that
doing the fasting blood sugars in these children.
no. It's also important that you don't need a fasting blood sugar.
In some
What does
of
it tell
them-
you? Doesn't tell you anything. It can be sepsis. It can be
but you have to
galactosemia.
understand that some of them may not come to you. The ones whom you really can help, are the ones who may not come to you with a clear-cut random blood sugar showing as hypoglycemia. In those cases, we'll have to do this.
No, but it doesn't help you to make a diagnosis. What you need is a urine reducing
Srinivas,
sugar.
It doesn't
Yeah,
help you,
reducing
but it doesn't help you, but everybody does. I think everybody does.
Reducing sugars, of course, are much better.
John, this is more plausible for glycogen storage disorder where controls are not good. For galactosemia, we should not chase hypoglycemia is there or not. There are many other pointers to say whether it is galactosemia. So I don't
Yes,
think
definitely.
we should chase this hypoglycemia business.
Yeah.
You've got a child presenting to you on day 1. You picked up the cataract. You started the workup. Should you stop
Oh, yeah.
galactose
Yes.
at that particular
I think
time?
इस सेक्शन में कर लेंगे. हमारे बहुत लिवर पर है ना, we'll take a call on that question whether we should stop.
Yes, okay, I'll just finish this one point, that the minute I either get 3 NGRS positive, I get cataract positive, I will stop the galactose and I put him on galactose-free diet and wait for my GALT report to come. And depending on that, I'll go further.
This can be done. This is any child who comes with ALF, for instance, is an infantile, newborn, I would like to put on galactose-free diet till the time you prove it. Second thing is you put them on acyclovir because herpes infection is there. Till the time you prove it, it takes 6 days, 5 days, 7 days. So these two things have to be done in these patients. On suspicion, and you can restart also. There is no problem.
Thank you very much.